Today, we are unpacking the secret, highly localized language of the human body. Specifically, we're looking at a group of chemical messengers known as autocoids.
Right, autocoids.
And our mission here is to explore how modern medicine basically hacks these local messages to treat, well, everything from seasonal allergies to severe migraines.
It's fascinating because it fundamentally changes how you view your medicine cabinet. You start to realize that pharmacology isn't always about, you know, introducing some foreign alien substance to kill a disease.
Right.
A lot of the time, it is really just about intercepting and rewriting the chemical text messages that your own cells are sending to each other.
I love that phrasing, by the way. Chemical text messages. Let's break down that word first, autocoid, because it perfectly sets up how this whole system operates.
Yeah, the origin of the word tells you exactly what it does.
Right. It comes from the Greek autos, meaning self, and akousis, meaning remedy or medicinal agents. So literally a self-remedy.
A self-remedy, exactly.
And to kind of visualize this, if traditional hormones like adrenaline or cortisol are an agent email sent out to the entire company.
Like hitting Zendol.
Yes, you hit
Yeah.
send all and the whole body goes on high alert. But autocoids operate completely differently. They are like a physical sticky note left directly on a neighbor's desk.
That is the perfect analogy.
They are produced by tissues right exactly where they are needed rather than being, pumped out by an endocrine gland to just travel everywhere.
The sticky note analogy captures the sheer locality of these messengers perfectly. And understanding that hyperlocal nature is really the key to manipulating them.
Because they don't go far.
Exactly. The major autocoids we're looking at today, prostaglandins, histamine, and serotonin, they are the ultimate local regulators. They manage the microenvironments of your tissues.
Okay.
And because their natural effects are so localized and powerful, if a pharmaceutical drug can mimic that sticky note or block someone else from reading it, well, you can control the cellular conversation without having to put the entire body on lockdown.
That makes so much sense. So let's look at the first major category of these local sticky notes in our sources, prostaglandins.
The multitaskers.
Yeah, they really seem to function as the body's ultimate multitaskers, doing just incredibly diverse jobs depending entirely on where they happen to be produced.
They do. And from a purely biochemical standpoint, prostaglandins are derived from unsaturated fatty acids.
Okay, stop right there. What does that actually mean in practical terms for you and me?
It means they are literally built from the fat molecules that make up the walls of your cells.
Oh, wow.
Yeah, so when a local tissue needs to send a signal, it literally snips a piece of its own cell membrane, converts it into a prostaglandin, fires it off, and then
Wait, it uses its own wall.
its own wall.
Yeah.
And then that molecule acts extremely rapidly on the neighboring tissue before being metabolized into an inactive product within, moments.
So they do their job and they just vanish.
Exactly.
Like a lot.
They are incredibly fast.
But wait, if they are so effective and fast-acting, why isn't there just a general, prostaglandin pill for everyday ailments?
Oh, because that would be a nightmare. They trigger an incredibly bewildering array of effects all at once across totally different tissue types.
So it's not a single specific action.
Not at all. If you flooded the systemic bloodstream with prostaglandins, it would be physiological chaos. I mean, your blood vessels might dilate while your airways constrict, and your digestive tract goes into absolute overdrive.
Ah, yikes. So systemic administration is largely useless.
Completely useless.
Yeah.
To harness them clinically, you have to be incredibly targeted.
And that targeted approach leads to some highly specific, incredibly potent medical applications. And looking at our source material, one of the most significant clinical uses of synthetic prostaglandins is their application as abortifacients.
Right, agents used for pregnancy termination.
Exactly. And just a quick note for you listening, whenever we cover sources that touch on socially or politically charged topics, we always remain strictly neutral. We are not taking any political or moral side here. We are simply conveying the objective pharmacological facts directly from the source text.
Just the science of how these autocoids work.
Exactly. So this specific medical application relies entirely on the profound localized effect that prostaglandins have on the smooth muscle of uterine tissue.
Yes. The established medical regimen detailed in the text involves a two-step pharmacological process. It begins with the oral administration of a drug called mifepristone.
Which is a synthetic steroid, right?
Correct. And mifepristone acts by blocking the body's progesterone receptors. So it essentially halts the physiological support for the pregnancy.
And then the autocoid comes in for the second step.
That's right. 48 hours after the mifepristone, the protocol calls for misoprostol.
which is the synthetic analog of prostaglandin E1.
Exactly. By introducing that synthetic prostaglandin directly into the system after the progesterone has been blocked, it strongly stimulates the uterine muscle to contract,
Because it's mimicking the body's natural signaling process.
mimicking the signal to expel tissue, yes.
And the clinical outcomes for this specific two-drug protocol are highly documented in our sources. They note it results in complete abortion rates that exceed 95%.
Very high efficacy.
And the overall case fatality rate associated with the procedure is less than 1 death per 100,000. They do also list common complications, which can include infection, hemorrhage, and retained tissue.
Right.
So we have this synthetic prostaglandin acting as a super powerful stimulant on smooth muscle. But here is the bizarre twist of pharmacology that the text points out.
I love this part.
Misoprostol, that exact same synthetic autocoid, is prescribed for a completely different condition, protecting the stomach from peptic ulcers.
It sounds contradictory, doesn't it?
It really does. Why on earth would someone need a synthetic cell messenger just to protect their own stomach lining?
Well, it goes back to that friendly fire we mentioned earlier. Specifically from other medications, millions of people take NSAIDs every single day.
Like ibuprofen or aspirin, non-steroidal anti-inflammatory drugs.
Exactly. So you take an aspirin to stop the pain of a sprained ankle. The way aspirin actually stops that pain is by inhibiting your body's ability to produce prostaglandins right at the site of the injury.
Which reduces the inflammation there.
Right. But the aspirin doesn't know it's only supposed to work on the ankle.
Oh, it goes everywhere.
It goes everywhere. And that is precisely the problem. Because in your stomach, your natural prostaglandins aren't causing pain. They are acting as a protective shield.
So they are doing a completely different job in the gut.
Completely different. They send these constant local signals to inhibit gastric acid secretion, and they enhance the mucus lining that literally protects the stomach wall from digesting itself.
Wow. So when the aspirin shuts down prostaglandin production globally to fix your ankle,
It accidentally strips away the stomach's natural armor at the same time.
so the acid just eats the stomach lining, causing an ulcer because the sticky note saying, hey, keep the acid down, got thrown in the trash.
That is exactly what happens. So doctors prescribe misoprostol to artificially replace those missing local messengers in the gut. The synthetic autocoid steps in, inhibits the acid, and protects the stomach.
Okay, but there's a catch, right?
There's always a catch. Manipulating the gut's microenvironment has a cost. Misoprostol frequently induces intestinal disorders and severe cramping.
Because it's stimulating smooth muscle again.
Right, you can't completely isolate the effect.
Yeah.
Because of that side effect profile, modern medicine often prefers proton pump inhibitors now. Drugs like omeprazole.
Oh, sure. Omeprazole.
Yeah, they manage stomach acid by bypassing the autocoid system entirely and just shutting down the acid pumps directly. It's often much better tolerated.
Okay, so we've seen how prostaglandins act as a protective shield or a muscle stimulant. Let's pivot to an autocoid that serves a very different role. The body's local alarm system when tissues are actively under attack. Histamine.
Histamine, yes. It is a chemical messenger mediating allergic and inflammatory reactions. But what is truly fascinating here is how the body strategically deploys it.
Where does it hide?
It is highly concentrated in areas where the inside of your body meets the outside world. The respiratory tract, the skin, the gastrointestinal lining.
So it's basically the biological border patrol.
That's a great way to put it.
It just sits there, stored safely away inside immune cells, called mast cells and basophils, wrapped up in these little inactive granules alongside a compound called heparin, just waiting for a breach.
And a breach can be almost anything that damages cells. Extreme cold, bacterial toxins, physical trauma, or, a bee's injecting venom.
And what happens when the breach occurs?
Any of those events cause the mast cells to literally shatter and dump their histamine payload directly into the surrounding tissue.
That dumping mechanism brings up a terrifying biological reality from the reading. The difference between a localized allergic reaction like getting a runny nose from breathing in pollen and full-blown, life-threatening anaphylactic shock. It isn't about different chemicals.
No, not at all.
It is entirely about the speed of the histamine release.
Yes. The speed is everything. The body has enzymes designed to inactivate histamine once it enters the bloodstream. So if you inhale pollen, mast cells in your nose release histamine slowly.
You get local swelling, you get the sniffles.
Right, but as it trickles into your blood, those enzymes break it down safely. A drip is manageable. But if you have a severe peanut allergy and you eat a peanut, millions of mast cells across your entire body detonate simultaneously.
They all go off at once?
All at once. That massive rapid dump completely overwhelms the inactivation enzymes. The alarm system basically crashes the entire biological grid.
That is terrifying. So how does this chemical actually cause the physical symptoms we feel? The text says it acts on a few different receptors, but clinically, the heavy hitters are the H1 and H2 receptors.
Exactly. When histamine binds to the H1 receptor, it kicks off a chain of defenses aimed at physically expelling the invader.
Like what?
Well, it forces increased production of nasal and bronchial mucus. It's literally trying to trap the invader in slime.
Lovely.
And it constricts the bronchial smooth muscle, which restricts airflow. That constriction is what causes the terrifying shortness of breath during an asthma attack.
And what about in the gut?
Down in the intestines, H1 stimulation causes severe cramping and diarrhea. Again, just forcefully trying to expel whatever triggered the alarm.
So H1 is doing all of that, but both H1 and H2 receptors sort of tag team the cardiovascular system, right?
They do. They cause systemic blood pressure to plummet by reducing peripheral resistance in your blood vessels. And they force the capillaries to dilate and become highly permeable.
I think the text used a garden hose analogy for this.
Yeah, think of the capillaries like a garden hose. Histamine essentially pokes tiny holes in the hose, allowing fluid to leak out of the blood vessels and into the surrounding tissues.
Which creates a very specific, visible marker on the skin. The text called it the classic triple response.
Oh, the triple response is fascinating.
If someone injects histamine directly into your skin, 3 things happen. First, a wheal forms. A raised bump caused directly by that fluid leaking out of the capillaries.
Right.
Second, you get reddening right at the site, which is the local blood vessels dilating. And third, a flare, like a wider, jagged halo of redness spreading around the bump caused by local nerve reflexes.
You are literally watching the alarm system manifest in real time. It's incredible. But because it is solely an alarm, histamine itself has absolutely zero clinical applications.
Right. No physician is ever going to prescribe you a shot of histamine to make you feel better.
Never. The real medical magic is in muting the alarm. Which brings us to the antihistamine evolution.
Yes, physically blocking those H1 receptors so the histamine has nowhere to dock. And pharmacology divides these drugs into 2 very distinct eras, the first-generation drugs and the second-generation drugs.
Right. The first-generation antihistamines include older medications like diphenhydramine.
Which most people know as Benadryl.
Exactly, or promethazine. They are incredibly effective at blocking histamine, and they are very inexpensive. The problem is they're entirely nonspecific.
Which led to the second-generation drugs, right?
Yes, drugs like loratadine Claritin or fexofenadine Allegra, they were developed decades later specifically to solve the massive side effect problems of that first generation.
And the most famous side effect being that a first-generation pill will basically knock you unconscious.
Oh, absolutely.
So why is that? Why do the older allergy meds make you feel like a heavily sedated zombie, while the newer ones let you clear your sinuses and then, go drive a car and live your life? Is it just a dosage thing?
No, it's not dosage. It is entirely about chemical structure and a biological fortress called the blood-brain barrier.
Okay, break that down for us.
So, your brain has a specialized membrane protecting it from toxins in the blood. The older first-generation drugs are highly lipid-soluble. That means they easily slip right through that fatty barrier and straight into the central nervous system.
And what do they do once they get inside the brain?
Once inside, they don't just stop allergies. They bind to H1 receptors in the brain, blocking histamine's secondary role.
Wait, histamine does something else in the brain?
Yes, in the brain, histamine acts as a critical neurotransmitter for wakefulness. So you shut down the wakefulness pathways, and you get heavy, overwhelming sedation.
So the pharmaceutical industry realized they needed a drug that could fix the nose, but couldn't pick the lock to the brain.
Exactly. So they engineered the second-generation drugs to carry specific polar chemical groups. Think of polarity like trying to push the 2 wrong ends of a magnet together.
They push each other away.
Right. Because of those polar charges, the second-generation drugs physically repel away from the blood-brain barrier.
That is brilliant chemistry.
It really is. They are trapped in the periphery of your body, fixing the itchy skin and the runny nose, but leaving your brain's wakefulness centers completely untouched.
But sedation is only half the problem with the older drugs, according to the text. Their lack of specificity causes a massive ripple effect of collateral damage.
It is massive.
First-generation antihistamines don't just accidentally block histamine in the brain, they also accidentally bind to completely unrelated receptors, like cholinergic receptors alpha-adrenergic receptors, and serotonin receptors.
Yeah, they are very messy drugs. When a drug binds to a cholinergic receptor, it interferes with the body's parasympathetic nervous system.
The rest and digest function.
Exactly. So by trying to stop a sneeze, you accidentally block the nerves controlling your saliva production and your bladder.
Which results in extreme dry mouth, urinary retention, sinus tachycardia, and blurred vision. The drug interactions are incredibly serious, too.
Very serious.
The source notes that patients taking MAOIs, which is a class of antidepressants, can experience dangerous exacerbations of these anticholinergic effects if they take a first-generation allergy pill. They can even counteract medications used to treat Alzheimer's disease, like Dunpisol.
And the stakes of those side effects dictate real-world medical decisions. The study questions in the source had a great practical example of this. Consider a scenario of a 43-year-old commercial ship's captain who develops severe seasonal allergies while on duty.
You absolutely cannot give a ship's captain or an airline pilot or a crane operator a first-generation drug like diphenhydramine.
It would be medical malpractice.
You must give them a second-generation drug like fexofenadine. The older drugs so profoundly impair motor coordination and wakefulness that giving them to someone operating heavy machinery is just a recipe for disaster.
But pharmacology loves a paradox.
It really does.
Those massive, disruptive, unwanted side effects of the first-generation drugs. Under the right circumstances, they are exactly the primary mechanism a doctor is looking for.
The bugs become the features.
Exactly. Because they so effectively cross into the central nervous system and disrupt cholinergic receptors, certain first-generation antihistamines, like meclizine or dimenhydrinate, are the absolute best agents we have for preventing motion sickness.
Oh, because they block those specific pathways.
Right, they step into the brain and block the neurological pathways that mediate nausea and vomiting.
And the sedation effect is actively marketed, too. Drugs like diphenhydramine or doxylamine are sold over the counter as somnifacient sleep aids.
Right.
People buy them to treat insomnia specifically because they knock you out so efficiently. It's the exact same chemical structure, just deployed to weaponize its side effect rather than cure an allergy.
It perfectly demonstrates that a drug's value isn't just in what it was designed to do, but in understanding everything it does across the entire biological system.
That is so true. All right, let's leave the gut and the immune system behind and move strictly into the brain. We need to focus on a specific debilitating condition tied heavily to our third major autocoid, serotonin. We are talking about headaches.
The scale of headache pharmacology is immense. Tens of millions of people suffer from severe, incapacitating migraines.
To understand how serotonin plays into this, the text isolate migraines from other common headaches. You have cluster headaches, which are excruciating, sharp, steady pain, usually located right behind one eye.
And curiously, they affect males significantly more often than females.
Right. Then you have tension-type headaches, which feel like a dull, persistent bilateral band tightening around the entire skull. But migraines are a completely different beast.
Very different.
They are pulsating, throbbing, incredibly severe, usually unilateral, meaning they stripe one side of the head, and they affect women threefold more likely than men.
The true autocoid connection becomes visible in the biology of the migraine, particularly the roughly 15% of migraines that are preceded by an aura.
The aura is terrifying if you don't know what's happening. Flashing lights, blind spots, tingling in the face occurring 20 to 40 minutes before the pain hits. What is actually happening in the brain tissue during an aura?
Neurologists track it as a phenomenon called spreading depression.
Spreading depression.
Yeah. Imagine a slow-moving wave of reduced electrical activity creeping steadily forward over the surface of the brain's cortex. As this electrical wave washes over the brain, it is accompanied by severe hypoperfusion.
Meaning a drastic reduction in localized blood flow to those areas.
Exactly. The brain tissue is temporarily starved of blood.
So the electrical grid browns out and the blood supply drops. But then the headache hits and the environment flips entirely.
Right. The reduced blood flow persists into the early headache phase, but then you experience massive hyperperfusion. A violent rush of blood surges back, causing the extracranial and intracranial arteries to dilate and stretch far beyond their normal capacity.
The plumbing suddenly gets overloaded with too much pressure.
And that extreme, rapid stretching of the blood vessels forces the local tissues to release neuroactive molecules, specifically pro-inflammatory neuropeptides. It is the release of those chemicals, triggered by the stretched vessels, that causes the agonizing, pulsating pain of the migraine.
Wow. So how do we use an autocoid to stop the stretching? The specific pharmacological intervention mentioned is a class of drugs called triptans, sumatriptan, rizatriptan. How do they hack serotonin to fix the plumbing?
Well, triptans are serotonin agonists.
Remind us what an agonist is.
An antagonist blocks a receptor, but an agonist mimics the natural chemical to trigger the receptor into action. But triptans don't just trigger any serotonin receptor. They are incredibly highly targeted to act almost exclusively at a subgroup called the 5-HT1D receptors.
Where are those specific receptors located?
They are found right on the small peripheral nerves that innervate those painfully stretched intracranial blood vessels.
Oh, perfect target.
Exactly. When the triptan hits the 5-HT1D receptor, it sends a forceful command for those vessels to rapidly constrict back down to their normal size. At the same time, it actively inhibits the further release of those pro-inflammatory neuropeptides.
So by forcing the vessels to shrink, they effectively abort the migraine.
Yes, in up to 80% of patients.
It's an incredibly elegant solution, but clamping down blood vessels anywhere in the body comes with a serious risk, right?
A vital contraindication. Because triptans actively cause vasoconstriction, they absolutely cannot be given to patients who have underlying risk factors for coronary artery disease.
That makes sense.
If you introduce a drug that constricts arteries into a patient whose heart arteries are already compromised, you risk inducing a severe cardiac event. A thorough cardiac evaluation is non-negotiable before administration.
And for patients who can't take triptans or for whom they fail, the text mentions alternative angles of attack. There is dihydroergotamine, an older drug given intravenously.
Right.
It stops the acute attack with similar efficacy to sumatriptan, but it frequently causes severe nausea. And importantly, it is strictly contraindicated in pregnancy because, much like the prostaglandins we discussed earlier, it causes severe contractions in uterine tissue.
And if a patient is suffering from these intense vascular storms more than twice a month, you move away from treating the acute attack and focus on prophylaxis.
Preventing the storm entirely.
Exactly. The drug of choice for migraine prophylaxis is actually a beta blocker called propranolol. It works to stabilize the cardiovascular baseline so that hyperperfusion wave never gets triggered in the first place.
It really demonstrates the multi-layered approach required when dealing with localized chemical systems. You need one tool to intercept the emergency message and a completely different tool to prevent the message from ever being drafted.
It is a massive, intricate biological puzzle.
It really is. So let's step back and look at the territory we've covered today in the body's local communication network. We started with prostaglandins, those rapid-fire fatty acids acting as local armor for the stomach lining, yet powerful enough to terminate pregnancies.
Right.
We moved to histamine, the body's border patrol, sitting quietly in mast cells until a breach triggers an alarm that can manifest as a mild itch or escalate into systemic shock based purely on the speed of the chemical dump.
And then the brain.
And finally, serotonin agonists, the triptans. Highly specific chemical keys designed to clamp down forcefully on dilated brain vessels to stop the agonizing electrical storm of a migraine.
You know, the true value in grasping this microscopic reality is that it fundamentally redefines your relationship with modern medicine.
How so?
Well, the next time you take a simple allergy pill before going outside, or swallow an NSAI for a headache, realize that you aren't just magically dissolving a symptom. You are actively participating in a highly sophisticated, deeply complex pharmacological negotiation with your body's most intimate messengers.
You are intercepting, rewriting, and replacing the sticky notes of your own cells.
Exactly.
It absolutely changes the way you look at a pharmacy. And I want to leave you with a final thought to mull over, building off the reality of the histamine alarm. We discussed how a local autocoid like histamine can be the difference between a slightly annoying, mildly itchy patch of skin and full-blown, life-threatening anaphylactic shock. And the difference between those two extremes isn't the chemical itself, it is purely based on the speed of its release.
Right, a slow drip is an annoyance. A rapid dump is fatal.
Exactly. It makes you wonder how many other microscopic, invisible systems in our bodies are riding that exact same razor's edge between total flawless health and total system failure every single second, completely without our conscious knowledge.
It is a humbling reality to realize how delicately balanced the human machine truly is.
It really is. Well, thank you so much for joining us on this deep dive. We'll catch you next time.